appreciate you taking time off your busy schedules to join us today, both in person and through online by joining the webinar. We hope you will find the program fruitful and engaging. The events proceeding are as follows. Opening of the program, updates on the management of chronic kidney disease. Number 2, opening remarks by Professor Tuzate. Number 3, academic program of CKD, Can We Delay the Progression by Dr. Thiha. Number 4, academic program of nutrition and CKD, Hemodialysis disease by Professor Pham. Number 5, closing remarks on the symposium, updates on the management of chronic kidney disease by Professor Tuzate. And number 6, closing of the program, updates on the management of chronic kidney disease. So according to agenda number 1, may I announce that the ceremony of updates on management of chronic kidney disease begins. According to agenda number 2, I would kindly like to invite the Honorable Chairperson, Professor Tuzate, Senior Consultant Nephrologist, up on the stage for the opening remarks. Professor, please.
Very good afternoon, all the respectable CIE and colleagues who attending the symposium in person or online. Updated KDIGO 2023 guideline described that the global burden of the disease, injury and risk factor study, GBB, pulled together data on premature death, disability from more than 350 diseases and injury in 204 countries by age and sex from the 1990 to the present. Disease burden is an impact of the health problem as measured by financial cost, mortality, morbidity, or other indicators, and can be measured by combining the two indicators to describe the disability adjustable life year, DLIS, the number of years of life lost to the disease and number of years lived with the disability due to disease. Globally, in 2017, systemic analysis from the All-Age Global Burden Disease Project found 697.5 million cases of all stages of CKD for a global prevalence of 9.1%. By the 2021, a joint statement from the American Society of Nephrology, European Renal Association, and International Society of Nephrology indicated that more than 850 million suffer from some form of kidney disease. Roughly double the number of people who live with the diabetes. Diabetes incidence 422 million and more than 20 times the prevalence of the cancer worldwide, 42 million of people living with the acquired immune deficiency syndrome or infection, 36.7 million. In 2017, death of the people with the CKD is 1.2 million and increased to the 1.43 million in the 2019. So CKD death has risen from the 19 to 11 in rank among the leading cause of death between the 1990 to 2019. But currently, the kidney disease awareness remain low in the worldwide. Only 6% of general population and 10% of the high-risk population are only aware of their CKD status. So they advocate that CKD detection to be integrated with the patient and family education and the engagement to improve the assessing appropriate healthcare and knowledge and the adherence to recommended lifestyle modification and medication. So slowing the CKD progression at the early stages should provide the economic benefit and prevent the development of kidney failure and cardiovascular complication. So today, the symposium on the update on the management of the chronic kidney disease, two speakers will discuss about the update on the management. First speaker I will invite is the Dr. Thiha, consultant nephrologist, Department of Nephrology from the Yangon General Hospital. He will be discuss about the CKD. Can we delay the progression? May I invite the Professor Dr. Thiha.
Good afternoon, Madam Chairperson, CIE Professor Commandant, and Professor Pham, and also my dear colleagues. It's a great pleasure to me and honor to me for getting a chance of participating in this CME program as a speaker. And Professor Pham, welcome from Myanmar, and thank you very much for coming here and giving us a lecture. Professor Pham, can I talk in some explanation in bilingual? Is that okay? So today I will discuss about the CKD, can we delay the progression? So as you all know, the CKD is a very high prevalence, as Professor Thiha had mentioned, and it can be defined as if the anomalous and kidney structure and function for more than 3 months. So the prevalence also very, the rank is very high from 19th position to 5th position in around about 2040. And how about the prevalence in South Asia region? So the global is around about 9%, and South Asian is also the around about 10%. Vietnam, Myanmar also not much different. And as you all know, the stages of CKD can be classified according to their GFR from stage 1 to 5. You already know. And so we are defining the CKD staging by an EGFR. So to calculate the EGFR, we have to measure the serum creatinine. So and then we calculate the formula or equation. So is it reliable marker for so creatinine? Is it reliable, and is there any limitation for that? So in 2023, KDIGO guideline highlight the pitfalls of the serum creatinine because it can be some like the lean muscle, the too thin or too fat, or there's a too much muscle mass, or taking the too much protein diet. So there may be that the serum creatinine may be misleading measurement. So they recommend that to wait at least 12 hours before measuring the serum creatinine to fast a meat or fish, or to need to fasting fast and they also recommend the cystatin C-based estimated glomerular filtration rate in some circumstances. So they recommend the EGFR by measuring the creatinine or also the cystatin level in some of the circumstances. Because if the patient is amputated, or there's a muscle is too wasted, or there's a too muscular man, it can be misleading. So for creatinine, the muscle mass, it may be the misleading that two H3 of the body habitus, and also in the some specific condition. So cystatin C can be used, but be aware cystatin C also has the pitfalls. In patient with the steroid using or thyroid use or thyroid disease or cancer, it can be misleading. So they recommend to use a combination of cystatin C and creatinine to calculate the eGFR. And the another thing is they recommend to use a validated eGFR estimating equation like the MDRD or CKD EBN or something like that. So and to use the same equation, so the cardiac to it, who patient who creatinine cell 2 မျိုးပေါ့နော်သူဆေးရုံကြီးတစ်ခုမှာဆက်တာတစ်မျိုးရှိတယ်အပြင်မှာဆက်တာတစ်မျိုးပေါ့နှစ်ခုသူတို့ပြောတယ်အဲ့တော့ရှင်မျိုးထွက်လာတယ်ဆိုတော့ကြည့်လိုက်တော့နှစ်ခုကတော့တကယ်တော့ milligram per cent နဲ့ micromole ဆိုတော့မြောက်နေသိမကွာဘူးပေါ့နော်ဒါပေမဲ့ပြဿနာကဘာလဲဆိုတော့သူ eGFR equation လေးကွာနေတာတခုကတော့ EPN နဲ့တွက်ထားတယ်တခုကတော့နည်းနည်းလေးကွာတာလေးရှိတယ်ပေါ့နော်ဒါမှမဟုတ်ကျွန်တော် to use the same equation more they recommend. So this natural history of the CKD, as you know, there's an albumin-urate pathway, which we have been discussed already a long time ago. And from normal albuminuria to microalbuminuria is an incipient stage. It can be reversed to normal albuminuria. If it progresses to microalbuminuria, it's very hard to reverse to normal albuminuria, and what we call the overt nephropathy. This is a normal albumin-urate pathway. So then after the microalbumin and macroalbumin, and then the GFR will reduce and it will lead to CKD-ESRD. So this natural history of the previous. Okay, how about now? So in addition to microalbumin-urate pathway, there is also the non-albumin-urate pathway. Because some of the patients can go the reduced GFR and undergoing to CKD or ESRD without albuminuria stage, because there's some macrovascular disease and some repeated AKI, which we don't know and sometimes, and it was about 30 to 40%. So so in addition to microalbuminuria, we need to emphasize an non-albuminuria pathway. So that's why now the natural history is changing. So albuminuria can lead to CKD, and also without albuminuria, it can lead to CKD. So what about the risk of albuminuria pathway? And they found that there's some community acquired AKI, because if the patient is admitted and the patient got the AKI in hospital, it's a hospital acquired AKI. We can know easily because we are measuring the creatinine and we can calculate the eGFR. But in the community, we cannot know because they don't measure the creatinine, and we cannot know by not doing the testing. So they emphasize on the community acquired AKI. So there you can see there's an incidence outcome and risk factor. The community acquired and hospital acquired both can lead to the CKD progression. So kind of journey nephrosis harvest traditional medicine research machine see the patient got the diabetes separation good over patient risk is she needs when you Dalia, the non-albuminuria pathway in a ton of jamlo, Sarasama Chubiro, GB clinic the general Povito, not through Total line, general see your tea, not through CKD, so your tea, Jumion, or Tabinham, and Damla, the community choir, it can live when I say she will lower. So how about the roles of primary care providers? So you can identify and evaluate the patient at risk, and you can detect the CKD, and you can manage the CKD, which we will discuss later, and also refer to nephrologists if appropriate. So there's a referral criteria for the nephrologist for specialist clinical service. And if the diagnosis in doubt and the cause of the CKD is unknown, and there's some reduction in GFR less than 30 in CKD stage 4, and there's some patient presenting with the albuminuria and hematuria, which was like the nephrotic or nephritis syndrome, and then it's the advanced CKD with the complications. So you can refer to the specialist renal care service. So our first discuss with diabetes nephropathy. So you all have been known that diabetes is a major cause of the CKD, and you all have been known that glycemic control, importance of glycemic control, blood pressure control, the cardiovascular risk reduction, and the use of the RAS inhibitor for treatment of the diabetes nephropathy. So for concerning with the glycemic control, the chronic hyperglycemia is a fundamental cause of the renal complication. So we need to control the blood sugar. And so it being shown in the UKPDS, the intensive care of the targeting the A1C less than 7. So it can reduce renal complications. It can reduce the macrovascular complications. And the advanced trial also support for that. And it supports the renal productive effect of the glycemic control on diabetes kidney disease. It's mainly based on the albumin urate reduction. So in reviewing the Ngoc trial, so in that study, there's a tight glycemic control less than 6. So the study was prematurely stopped because of the high mortality in the very strict control group. So the mortality patient were found to have the CKD patient. So be aware of the very tight and glycemic control in the CKD. The CKD pitoma, advanced pitoma, sugar go yang control လိုက်လို့ရင်ကျွန်တော်တို့ကတခုပြည့်မှထုံးကြတာလိုမျိုးပေါ့နော်ကျွန်တော်တို့ကဒီ risk တွေပုံများနိုင်ပါတယ်ဒါမှမဟုတ်ဆရာဆောင်အနေနဲ့ social series ဒီသူပြော legacy effect ပေါ့နော် metabolic memory ဆိုတော့ social series ခုကိုပြောကြတယ်အရင်နောက်ကျသွားပြီဆိုရင်တော့ tight glycemic control ကိုတော့ against the tight glycemic control ပါ especially in frail patient elderly comorbid conditions เนาะဒါဆိုကျွန်တော်တို့ကဖြစ်နိုင်ရင်တိတ်ပြီးတော့ strict control မလုပ်ဖို့ပြောရတယ် so now the hemoglobin A1C is individualized so what are the limitations of A1C in CKD patient? Is it reliable in CKD? So for A1C, it is not be accurate in CKD ESRD patient because as you all know, there's anemia because of the rising lifespan reducing. And if the patient is not anemic, if the patient is on EPARD, the A1C may not be accurate. And also because of the method of gel electrophoresis method, which is there may be the false elevation in A1C level because of the uremia. So the A1C level may be elevated or maybe decreased in CKD patient. So you interpret with the cautiously, you should cautiously interpret with for that. So the 2023 KD go, 22 KD go, they recommend the A1C target of 6.5 to 8 according to their age, frivolity, and also the comorbidities. So we can monitor the glycemic control by continuous glucose monitoring or SMBG, sub-monitoring blood glucose. So this is a holistic approach of the kidney care risk. So lifestyle together with the medication. And how about the hypertension? And hypertension and CKD, or you also have been known this hypertension is a cause of CKD, and also CKD can cause elevation in blood pressure, and which may be very difficult to control. So for CKD patient, if the CKD is advanced, high incidence of the systemic hypertension because of impaired renovascular autoregulation and non-dependent or nodal blood pressure. So non-dependent if you Minnesota, my modality pomia, stroke, the MI, Yajare, down the CKD maso, 3 tavare, pressure maintenance was when the Pacale, the CKD will progress pieces to generate other severe risk telanhimare. So in renal trial, every 10 millimeter mercury increase in blood pressure increase the risk of CKD or ESRD and death by 6.7%. So if we control the blood pressure, we can reduce the risk of CKD and death. Benefit of the blood pressure reduction in UKPDS and advanced trial, type blood pressure control might be similar to or even more important than the reduction in CKD disease. So the blood pressure control is a major determinant of the beneficial renal outcome in STENO2 trial. So you can see easily here, this the red color is a tight blood pressure control, and this is tight glycemic control. The tight blood pressure control is more important than the tight glycemic control in patient with a CKD. So there's a slow risk in very tight glycemic control. So there's a renal benefit whatever the blood pressure level. So we need to control the blood pressure to achieve the target level. So how about the blood pressure target? So is there any new blood pressure target? So you can see this less than 130/80. There's a target level. And for CKD, less than 140/90. So CKD, young advanced line, young capare, the carolity majority or Tamos to be CKD advanced pillar, patient dialysis and so to Thiha capare, pitching a pigeon and go pip tail, the control me and machine that they want. Now, another thing is they emphasize to not to lower the blood pressure no less than 120/70. Why? because the sprint trial, they show the intensity blood pressure treatment group, there's an increased risk of the AKI, which is a very significant. So the exaggerated fall in blood pressure can lead to increasing creatinine level and be aware of the potassium level. So that's why trying to lower the blood pressure on target, but not trying too much lowering the blood pressure. So the latest recommendation of the blood pressure is less than 130/80, but not less than 120/70. So which agent should be used to control the blood pressure? So RA-assistant inhibitors like the ACR or ARB should be used for cardioprotective and renoprotective effect beyond their ability to control the blood pressure. So they can attenuate the progression of diabetes kidney disease in major landmark trial. That's why we are using the ACR or ARB to control the blood pressure. So another thing is the pleiotropic benefit of the RAS inhibitors. So the RAS inhibitors can reduce the albuminuria and also by targeting the glomerular hyperfiltration, reducing the glomerular hyperfiltration to retarding the renal inflammation and fibrosis. That's why we can get the pleiotropic effect by using the RAS inhibitors. So when to stop? If we are prescribing the ACR or ARB, you should check the creatinine baseline level, creatinine potassium baseline level, and then we should check 1 to 2 weeks later. And then if the creatinine changing, increasing more than 30%, or EGFR reducing more than 25%, we should stop and review the patient, need to review the patient. And also this is another recommendation, but be aware of the combination of ACI and ARB. So ACI or ARB combination should not be used for the treatment of hypertension because it can, and there's an increased risk of the AKI and hyperkalemia. So another thing is for CKD patient, we should aware of the source sensitive hypertension because our CKD patients are very salt sensitive, and so we need to advise the patient to restrict the salt intake. So given the antihypertensive medication, without restricting the salt, we cannot be successful for blood pressure control. So what is salt sensitivity? Because there's an increase in the quantitative trait, also the increase in sodium low disproportionately increase the blood pressure, what we call the salt sensitivity. The salt-sensitive hypertension is very common in CKD patient. So if you are treating the CKD patient, you need to advise for the salt intake. There are being a child, no, that is mean pure volume. So pure mabe thoroughly. There are meso when the peka and hypertension is easy pain in or take a level. So around 50% of the hypertensive patients are salt sensitive. And it's not only the salt, it's a deviation of the RA system, and also there's an increase in blood pressure, higher stroke risk, higher kidney disease risk, CVD risk, and also difficult to control in blood pressure. So the salt restriction is a very critical for advising the patient. So there's another, the lifestyle modification, and like the weight reduction, diet, dietary sodium restriction, physical activity, and alcohol. We can reduce systolic blood pressure, systolic and diastolic blood pressure. So we need to advise a lifestyle modification. So daily look down there over 30-40 lot to jina ni yara so totally miso wa mya. Damo jonori patient ni wo daily le pyo bo lo bare. So la re chima record ma dikalo control tisha mya o so in daily they advise bo lo bare. Now, another thing is mineralocorticoid receptor antagonist. If you are treating the patient with type 2 DM with CKD, the non-steroidal mineralocorticoid receptor antagonist, Renal, is a proven. They are the proven trial for the kidney and cardiovascular risk benefit. If the patient is GFR is more than 25, and the serum potassium concentration is normal, and there is albuminuria, you should prescribe the non-steroidal mineralocorticoid receptor antagonist. The Thiha or to show you like Pimarojania, she did the Thiha license or Matija, and so the non-steroidal MRE is a more proof for the patient with type 2 DN, and there's a high risk of CKD progression and cardiovascular events. So the patient hypertension she uncontrolled hypertension to heart failure to steroid tomare. CKD ne diabetes CKD progression page in a swino. If never know mono topic, Daria to a lemma triva, Tarima 3 the Quadria GFA go 25 pogo we sanara shiwari. GFR 25 if for patient CKD with GFR less than 25, there's a no safety data for that population. So use cautiously for patient with CKD. Because of another thing is that we need to monitor the potassium level. If potassium is more than 5.5, we need to stop it. And another point is anemia in CKD. So why we need to correct the anemia in CKD patient? As you all know, the CKD patient is associated with the anemia. It can contribute to the cardiovascular mortality. There's an increased risk of cardiovascular death in patient with anemia. So this is data from Brazil, France, Germany, and US. You can see there's an advancing the CKD staging. There's an increase in the prevalence of the anemia around about the 75% in CKD stage 5. So this is a pathogenesis of anemia. You all have been known. So CKD anemia so ne sa ma along di ho bo no EPA tin pie min ja de bo no di EPA tin ma thuk ta ri naw pi do di jano kong chen ni bo no iron ni ba ma shi da naw mo le di bek ka jano ri ta cha lan ni ya thwat ni da bo no GI loss si ta cha hemolysis ya ra ri naw pi do jano di ho bo ai pin ko plus there's a hepcidin bo no hepcidin ka to ro di chronic inflammation CKD ကြောင့်လည်းတက်လာနိုင်တယ်နောက်ခါကျွန်တော်တို့ဒီမှာ renal elevate လည်းမလုံးနိုင်တဲ့ကြောင့်တက်လာနိုင်တယ်ပေါ့ဒီတက်လာခဲ့ရင်ဒီ hepcidin level ကနေပြီးတော့ခါကျရင်ကျွန်တော်တို့ကအာယွန်းတွေရှိနေပေမဲ့လည်းကျွန်တော်တို့ကသုံးမရမျိုးဖြစ်လာတတ်တယ်ပေါ့ဒါမှမဟုတ်ဒီခါကျရင်ကျွန်တော်တို့ကဒီအာယွန်းကို check လုပ်တယ်တကယ်လို့အာယွန်းက normal ဆိုရင်တော့မှ you should be aware of that there's a functional iron deficiency in patient with the CKD because of the hepcidin level because the hepcidin inhibit the utilization of the absorption of the iron absorption in the intestine there's an iron but we cannot absorb there's an iron but we cannot use in RBC because of the hepcidin because it inhibit the uptake in absorption and recycling. So that's why at the time we call the functional iron deficiency. And the hepcidin level concentration is increasing with the increasing in CKD stage. And another thing is FCO, the FGF23, which is a very the notorious factor, it can be increased in the mineral bone disease and it can increase the mortality. And so if the hepcidin level is increased, there's also the increase in the FGF23 level. So it can also lead to the mortality and morbidity. So how about the target of hemoglobin? So if most of the guidelines recommend to correct the anemia if the less than 10, then the target should be 11.5 and around about 10 to 12. So we should not correct over 13 because there's a much increase beyond the 12. There's a increased risk of the cardiovascular death without additional benefit. So that's why the target should be around about 10 to 12. And we should use ion and ESA if there's a less than 10. So there's many type of ESA, you have alpha, beta, delta, and also the long-acting one. So we are using a lot, and these are the dose. And according to this trial, this is a very famous trial, it's to create NECD trial. They all shown that the increase in the correction of the anemia over 13 or 13.5, there's a thrombosis risk and also the cardiovascular death. So we should target the HE hemoglobin level to 11 to 12. So အများကြီးလောက်တာလည်းမကောင်းဘူးပေါ့နော်အများကြီး over correction ဖြစ်ကုန်လဲကျွန်တော်တို့ဒီ stroke risk တွေပါရကုန်ကြတယ်ပေါ့ So another thing is secondary analysis of the same RCT reveal that the response to ESA is more maybe important than the HP goal. That's why this finding raised a question whether the degrees of hemopoietic responsiveness to ESA rather than the target hemoglobin level should be taken into account in ESA therapy ပေါ့နော် So response ဖြစ်ရင်ကောင်းတယ်ပေါ့နော်ကျွန်တော်အရင်အများကြီးထိုးနေရရင်လည်းသတိထားရတယ်ပေါ့ပြန်ပြီးတော့ review ပြန်လုပ်ဖို့လိုတယ်ပေါ့ ESA hyporesonance ဖြစ်ပြီဆိုရင်ကျွန်တော်တို့ပြန်ပြီးတော့ဗာရမရှိတယ်ဆိုတော့ response ပြန် review လုပ်ဖို့လိုပါတယ် So the higher ESA dose may lead to poor outcome ပေါ့နော်ကျွန်တော်မတက်လို့တိုးဆိုတော့သတိထားပါတယ်ကျွန်တော်တို့ So how about the neurotherapeutic options in hemoglobin correction? So in CKD patient, there is evidence of retained EPO protection capacity. So you can see there's the attitude, the different attitude level. There's different levels of the EPO item. And so we are find this Chuvash in Russia, this population is polycythemia because of the high altitude, and they reduce the life expectancy because of the polycythemia. So this is a natural experiment. So baseline but there's a hypoxic inducible factor. If there's no oxygen or hypoxia condition, the heparin gene may be expressed. If there's a hypoxia, we need the oxygen, and the heparin production may be more. So the heparin gene will be transcribed, and there's a production of the heparin together with the heparin receptor. And if it will be activated on the hypoxic condition, because if there's an oxygen, the alpha subunits or HNF factor will be hydrolyzed by proline hydroxylase. So it will be breakdown and it cannot be transferred in case of oxygen. Oxygen oxygen HNF factor stabilize heparin gene transfer heparin stabilize endogenous there's a proline hydroxylase inhibitor available transfusion heparin enzyme this proline hydroxylase inhibitor this pathway hypoxia inducible factor pathway. So the agent injection we can use a hypoxia inducible factor proline hydroxylase inhibitor there's the HIF target gene proliferation angiogenesis mitochondrial function malignancy malignancy so this normal here, this is systemic hypoxia, there's an expression of the heparin gene. And so these are the agents, there's roxadustat and amaniadustat like here, and they are in the various stages of development. So first published in the 2019, September 12, and about 4 years before. And this is a phase 3 trial. Now they're the phase 4 on post-marketing study. And so in China, so the roxadustat was approved in 2018 December. Japan, China, Chile, Korea, Europe, EU, and the UK now in 2021, and they recommend to use roxadustat. So this is another alternative to ESA. So if the patient want to take the oral agent, if there is a ESA hyperresponsiveness, we can use an alternative. But the concern is a malignancy. But in the clinical trial, there's not showing the much increase in the malignancy risk. So, and another is a thrombosis advance in like the CVD risk or thrombosis in the EVF. And another thing is the liver dysfunction, retinopathy, hypertension, hyperkalemia, and pulmonary hypertension. And in polycystic kidney, the growing of the cysts. They are the concern. So they are using a lot in Asian Pacific region and also in the EU. So another is a circadian bone disorder. You have been known that there's a dynamic bone disease and the hyperdynamic bone disease. So we need to check the PTH assay, alkaline phos, calcium phosphate, and also there's a timing for checking the level, and we need to normalize the phosphate level because there's a risk of the calcifications and vascular calcification. We can use calcium containing and non-calcium containing, but now we prefer to use calcium not containing because calcium containing can lead to the calcifications, and we need to lower the phosphate level to the normal range, and then the PTH level should be 2 to 9 times upper limit or normal. So how about the metabolic acidosis? So metabolic acidosis is also the factor which can increase the risk of the cardiovascular and also the other mineral bone disease. So we need to correct it. And by using the dietary and or pharmacological treatment, so the 2023 guideline recommend to correct the bile gap is less than 16. The target is 22 or above. And so and another is the hyperuricemia. So patient with the people with CKD and symptomatic hyperuricemia should be offered the uric lowering intervention, which is a 1C. And initiating the uric lowering therapy to after the first episode of gout or if the serum uric concentration is more than 9 no. So the 9 လို့ကျော်ရင်တော့ဖြစ်တယ်လို့ပြောတယ်ပေါ့နော်ဒါပေမဲ့ uric nephropathy လည်းအားလုံးသိတဲ့အတိုင်းမှာကျွန်တော်တို့က more than uric တို့ကဒီ gout နဲ့ stone တွေမကောက်ပါဘူးအားလုံးသိတဲ့အတိုင်းမှာကျွန်တော်တို့က systemic hypertension တွေလည်းဖြစ်တတ်တယ်နော် glomerular hypertrophy တို့ glomerular hypertension တို့နောက်ပြီးတော့ကျန်တဲ့ဒီ adverse effect တွေမှာလည်းဒီ uric nephropathy တွေပေါ့နော်အဲ့ဒါတွေရတဲ့အတွက်ကြောင့်မလို့သူက lower လို့ဖို့တော့ပြောတယ်သူ US မှာလည်းသူတို့ဒီ data တွေမှာသူက2လောက်အပေါက်ကိုကျော်သွားပြီဆိုတာနဲ့ကိုဒီ kidney မှာ adverse effect တွေဖြစ်နေတယ်ဆိုတဲ့ evidence တွေအများကြီးရှိတော့ပေးဖို့ပြောကြတယ်ပေါ့နော် guideline အနေနဲ့ကတော့9ကျော်ရင်တော့ပေးဖို့တော့ပြောထားတာရှိတယ်ဒါပေမဲ့သူတို့တွေခုနောက်ပိုင်းဒီဟိုတော့ CKD ကတော့ CKD ဖြစ်ပြီး hyperuricemia တွဲနေပြီဆိုရင်တော့ဒါတွေကနော်ဒီချပေးနိုင်တယ်သူတို့ CKD progression ကို benefit ဖြစ်တယ်ဆိုတာတွေလည်းသူတို့ပြောပါတယ် and also we need to advise a dietary so the last thing is a lifestyle modification and this so we should encourage CKD patient to undertake the physical activity the 30 minutes per day at least 150 minutes per week not to use tobacco products avoid the smoking and refer to the providers and program if needed. And the higher consumption, they should be encouraged for higher consumption of the plant-based food and rather than the animal-based food and to lower the consumption of the ultra-processed food, which will be discussed by Professor Pham. And protein they should be restricted the 0.8 gram per kilo per day. I don't want to discuss detail because Professor Pham will be discussed for that. The ketone amino acid. So very low protein diet. I want to highlight here is a very low protein diet supplement with the ketonel improve the blood pressure control. So it can go the beneficial effect in CKD patient. So we also should encourage the patient to reduce the salt intake, which I have been already mentioned. This is the last slide of me. And so to delay the progression of CKD, so we need to encourage the patient to buy the nephrotoxic medication. You know, during material down here, several line, maybe already the indigenous medicine, the traditional medicine, the herbal medicine, the NSC and the one, down here, so CKD, purity, no, we don't tell you, Darwin and I drew to now to treat the lipid for the cardiovascular risk reduction, to optimize the blood pressure control, especially in the early stage. So advanced with the nearly low cadore, risk lemia, the jamolo, hyporisia, the modality potent hydrogen 3 tower, download slow the Sakon on the Yazlo, the Charlie's control people. Another thing is to control the blood pressure by using the ECN or ARV and treat the anemia and mineral bone disease if there is a and the reduction of the proteinuria by giving the glycemic control, pressure control, given the ECN or ARV, encourage a low protein diet and low salt diet, and encourage us to stop the smoking. So thank you very much for your kind attention.
Thank you, Dr. Thiha, for insightful presentation. For agenda number 4, I would kindly like to invite our Honorable Chairperson, Professor Tuzade, up on the stage again to invite Professor Pham Bu. Professor, please.
Second speaker is a professor, Pham Bu. Is a professor, head of Nephrology-Urology-Transplantation Department, Thach University of Medicine, Ho Chi Minh City, Pham University Hospital, Ho Chi Minh City, President Ho Chi Minh City Society of Nephrology-Dialysis Therapy. He's also the visiting professor at the Liege University, Belgium. He is nominated as an invited professor of Liege University, Belgium since 2005 and the pioneer in realization of chronic peritoneal dialysis and hemodialysis in the Vietnam and the kidney transplantation in Ho Chi Minh City, Vietnam. He also a leading investigator for many international trial researchers such as Rocky, Olympus, Daba CKD, Dialysis, Stabilize CKD, Sirius LN, and Screen. He's also an author for more than 250 publications on urology, nephrology, transplantation, and vascular surgery, and more than 50 books and theses on the various topics from the neurologist, cardiovascular disorder and disease, and chronic kidney disease, transplantation, extrarenal dialysis, hemodialysis, and peritoneal dialysis to the technique of vascular and abdominal surgery. I will happily invite the Professor Pham to deliver your knowledge regarding the nutrition in CKD dialysis disease. Professor, please.
Okay, while waiting the connection, first I would like to thank the organizer for having me to share our experience on nutrition with you today. And today I'm very happy when I see you again, my own colleague, when we met together during the GSDT Congress in Japan. Unfortunately, last year I didn't see them over there. And today I'm very happy to see them again. And okay. Okay, before my lecture, I would like to introduce you that in the of this year, from the 1st and the 2nd of December 2023, we will organize an annual congress of nephrology and dialysis. This year, we organize this conference in association with the International Society of Blood Purification. It will be taken in our city, Ho Chi Minh City, Vietnam. It's a very beautiful city. So I would like to invite all of you to attend this meeting. I think we have many international speakers right now. At least 9 speakers will come to Vietnam to present various topics regarding nephrology and dialysis. And all of you will be welcome when you come to our city. You know that when we have a meeting with the committee of ISPB, I defend for developing countries like Vietnam and Myanmar. For attending, when you attend the meeting, we only pay $20, while other countries, developed countries, have to pay $200 to $400 to attend this meeting. So we only pay 110, the price for this meeting. So I would like to invite all of you in person or online to attend this meeting in our series. Okay, now we go back to the topic today. How is what is the relationship between nutrition and kidney disease? There was recently there was a study, a cohort study you see on the table. In this study, there were more than 10,000 participants, and they encouraged all participants to have higher intake of such as legumes, fruits, whole grain, fish, low salt in the diet, and lower taken up processed meat, red meat, etc. And after more than 10 years, they found that when the patient have a healthy dietary pattern, that will be associated with a lower incidence of CKD and a lower incidence of albuminuria. That means that our diet will influence the kidney function very, very much. However, this idea is not new. During the year of 60, you see that Dr. Schreiber is very well known at that time. After the first dialysis, and he pointed out 3 case questions. The first one, how to better control blood pressure in patient on dialysis. The second one, how to manage chronic dialysis, chronic anemia. And the third one, which nutrition should be recommended to this patient. At the same time, another author from Italy, he said that in diet for chronic uremia, we have to fulfill 2 main and conflicting purpose. The first one is that how to lower the production of products from the patient. And the second one, we have to protect the patient body from wasting of protein. They are conflicting purpose of this patient. So because of that, until the year of 2010, they found the doctors found that what are the signs of pill? Are the symptoms already present before dialysis, and it is possible to correct the abnormality for this patient? That the first 2 questions already have the answer, but the third question we have no answer yet up to date. Because you know that now malnutrition we call in the common name is protein inertia wasting a pill. You know that pill can be happen. It's very common in both acute kidney injury and in chronic kidney disease. Even patient with dialysis. So this complication of malnutrition is very, very common in this patient. And so that you see that nutrition is very important. So that in the year 2020, the KDIGO launched a guideline specialized on nutrition for patients with CKD. So at the beginning of introduction of this guideline, they said that during progression of CKD, the requirement and utilization of different nutrients change significantly, which ultimately places patients with kidney disease at higher risk for nutritional and metabolic abnormality. So our responsibility is how to control malnutrition or metabolic or nutritional abnormality in these patients. Especially during the pandemic COVID, you see that poor nutritional status contribute greatly to the mortality of patients infected with COVID-19. And this kind of malnutrition, you see that it exists a very long time, just not only during the disease, but also after a very long time after disease, up to 6 months after infection, if the patient didn't die because of COVID-19. And you know that, fortunately, the prevalence of end-stage kidney disease is not very high, but you know that when the kidney progress to the end stage, the prevalence of malnutrition is very high. It's increased up to 70% of patients with end-stage kidney disease. It's the very common problem we have to face with for these patients. And not only this problem for developing or underdeveloping country, but it's also very prevalent in developed countries, like in you see that it is very common in the US, even in Europe, in other countries as well. That means that nutritional is always the problem we have to deal with for all patients with chronic kidney disease or dialysis. So why we have to pay attention to that? Because the presence of pill will increase the morbidity and mortality of patients with CKD or dialysis. So you know that there are many causes of pill. On the left of the slide, you see that before dialysis with the blue circle, you see that there's the loss of kidney function with resulting in urine toxin retention, the comorbidity condition of this patient, and the metabolic derangement and inflammation contribute to the prevalence of pill. And during dialysis, we have a dialysis-associated catabolism, which cause, we will see later, which contribute to malnutrition of this patient. And inflammation is the title which is paid attention to by many up to date, by many studies we will see. And of course, pill will result in higher risk of infection, higher risk of cardiovascular disease, and especially the frailty of this patient if the patient is quite old enough. And we should know that during the progression of kidney disease, the loss of the appetite happens very, very early during the progression of CKD. You see that just after the eGFR less than 10 to 20% of normal, the patient starts to have the anorexia, and this more and more common and more severe when the progression of CKD. And once the patient have dialysis, it's improved a little bit. Just at the beginning of dialysis, it lasts about 2 years only, and then the patient become to have or the appetite decrease after 2 or 3 years of dialysis, if the dialysis is not adequate. How about inflammation? You see that there are many causes of inflammation, and inflammation causes a lot of complications, as you see on the slide: muscle loss, anorexia, increased modulation of immune system, increased activity of SNS, it's increased complement activation, and even causing fever in this patient. And regarding the appetite, you see that when the patient has inflammation, it will inhibit the satiety center in the brain and resulting in the loss of appetite, and patient will present reduced protein and calorie intake, and in the end, they will lose of lean body mass. That is the pathophysiology of inflammation attacking our body when we have CKD. And this is a study a long time ago, when they evaluate the impact of the inflammation on the survival of the patient with CKD. In this study, they rely on CRP as a marker of inflammation. As you see on the table, that the mortality of the patient was lower if the CRP was higher. That means that the higher the inflammation, the higher the mortality of the patient, or the lower the survival of the patient with CKD. And another study also, when they divide into the appetite of patient of the CKD or hemodialysis patient into two kinds only: a good appetite or not good appetite. Patient with good appetite have a better survival during dialysis. So appetite is very important. And how about the dialysis associated with the catabolism? On the left side, you see that during dialysis, there are many factors affecting the appetite of patient and causing malnutrition. And all we know that dialysis not only eliminate uremic toxin from our body, but they also eliminate a lot of nutrient from our body. So if we don't pay to this nutrition, the patient will go into malnutrition state after some types of dialysis. And if we use less biocompatibility dialyzer, it causes a problem. If the patient is not dialyzed adequately, there's a problem. And if we cannot control other problem in this patient, we have also problem of nutritional in the patient. And as you see that, Kyaw is one of the very known professor regarding nutrition in CKD patient. You say that during dialysis, not only essential amino acid, but plasma total amino acid decrease during dialysis. You see dialysis or PD all have the decrease in the loss of amino acid during dialysis sessions. And when we compare between proteolysis and synthesis of protein, we see that in pre-dialysis on the left column, and during dialysis, you say that they lost a lot of protein. In other way, synthesis is less than proteolysis, and the consequence is that after dialysis, the patient lost 21% of protein from their body. So the patient lost a lot of protein during dialysis, and it lasts even some time after dialysis already finished. The muscle protein loss is the same. They also not only lost the protein of the body, but they also lost the protein from the muscle. Because of that, you see that their muscle become atrophic after some time of dialysis if we cannot supply enough of amino acid for this patient. And they say that about acute protein loss may occur both during and immediately after dialysis. This loss can contribute to a loss of lean mass from 1 to 3 kilo per year. So the patient can lose a lot of weight during dialysis if they cannot eat enough or provide any kind of protein to supply to compensate the loss. And when the patient lost more than 30% of muscle, there will a risk of increase of death as well as infection of the lungs. So how about the dialysis? In 2008, the nutritional committee in the world give 4 groups of criteria. In each group, we have many criteria. And if the patient have one criterion in 3 of the 4 groups, that means they have pure or malnutrition. And of the 4 groups, we have serum albumin, BMI, muscle mass, and dietary protein intake. Of the criteria, albumin, serum albumin is the most important marker, and it's happen very soon during the evolution of protein metabolic duration of this patient. And according to Professor Kantara, low protein means early death, and high protein means better survival. So we can say that of 4 criteria, serum albumin is the most important and the most early sign for the prognosis of this patient. As you see that, also a study by Professor Kantara, you see that higher the protein in the body, you see that the lesser the lesser the mortality of the patient. That means the higher protein albumin in the body, the survival of the patient is better. That's for patient on HD. For patient on PD, almost the same. Even in both patient HD or PD, nutrition is very, very important, especially their serum albumin is the indicator of their survival. And especially for patient with, I heard that you also have a patient with kidney transplantation here. And for patient with kidney transplantation, serum albumin is also play a role. If this patient present a low protein before operation, the outcome will be poor. If they have higher serum albumin before operation, the better outcome of the patient. So even the patient will have a transplantation, we have to prepare the patient very well regarding the nutritional status for this patient before operation. So we should guarantee their serum protein as much better as possible. And this is a guideline. They said that in the dose of CKD from 1 to 5 days, it's reasonable to consider using underweight status based on BMI as a predictor of higher mortality. And in another statement, they said that CKD 5D, that means CKD on dialysis, serum albumin may be used as a predictor of hospitalization and mortality in this patient. So that means serum albumin very easy to be done, but also very valuable marker for nutrition of this patient, so that we can intervene very effectively at the early stage of nutrition problem. How about the management? Our goals for nutritional in patient with CKD or dialysis, that's the first is to get them to have a positive nitrogen balance. Can we delay CKD progression? For this problem, there's no still very controversial about the role of nutritional intervention to delay the progression of CKD. It's still very, very big question. And optimal nutritional study. And our final goal is to improve quality of life as well as the survival of patients with CKD or on dialysis. So during pandemic, after a very long time to take care of this patient, they withdraw many conclusions in which they said nutritional therapy must be considered as integral part of first-line treatment, and should be implemented for both hospitalized and non-hospitalized patients. That means once patient getting infection COVID-19, nutrition is very important, and optimal intake of all nutrition, especially nutrients playing crucial role in immune system, because we can supply patient with many kind of nutrients, but we pay attention especially to what have a negative positive impact on immune system of the patient. Because one of the cause of dying during COVID infection is the low immunity of the body. So several meta-analyses also found that to promote the optimal function of immune system and to decrease and consequence of infection, the patient should intake some micronutrient, because even they should much more than not more, because to improve the immunity of the patient. And how to increase the immunity of the patient. Immunity of the patient includes TB, beta, T cell or B cell. B cell secrete immunoglobulin. What are immunoglobulin? Immunoglobulin are protein. So we can say that protein is the most important or the essential part of the diet. So today I would like to insist on the role of protein in the treatment of nutrition of this patient, because protein was have been considered as a building blocks of life. So we have to pay attention first to protein, and at this and regarding the protein, there are many discussions about low protein diet, normal protein diet, or higher higher protein diet is good for patients with CKD. We will see which one is more correct right now, up to date. I don't tell about tomorrow, but up to date. And according to KDIGO 2020, you see that for patients with chronic kidney disease and CKD, that means this kind of CKD may be due to dialysis, may be due to diabetes, or is a non-diabetic kidney disease. The patient must be treated with a comprehensive strategy comprehensive strategy. How? Why? To reduce the risk of CKD, the kidney disease, and to prevent the cardiovascular disease. And of the therapies, you see that there's a role of nutrition. That means that the nutrition is present in almost any kind of therapies. When we forget nutrition, we will be faint in the treatment of this patient. So nutrition. We have to pay attention to it. And what they say that my colleague in the first speaker, he also noted that for patient, they suggest that patient must maintain protein intake at least 0.5 gram protein per kilogram per day for patients with diabetes and non-dialysis. And you know that usually in patient, especially patient with CKD stage 3, majority of doctor tell patient that, oh, you should reduce vegetable, reduce the fruits because of the high risk of hyperkalemia. But now it changed. You see that they encourage patient consume a diet with high in vegetables and fruits, whole grain, fiber, legume, and plant-based protein and unsaturated fat. Why they have to take lower in processed meat, refined carbohydrate, and sweet beverage. But what I am like most is that this level of protein recommended is the level of protein recommended by WHO for everybody in the on the world. So that means that low protein diet may be not necessary anymore for patients with CKD. They should take a normal protein diet. Of course, it should not be very high. I will go back this title with the newer guideline you will see. And so we have to individualize and balance diet, high in vegetable, fruits, whole grain, and low sodium diet. You know, in 2022, endocrinologists and nephrologists in the US, they sat together and they gave a consensus on the nutrition for this patient. And so this guidelines is recommended by both guidelines in the US from KDIGO, that means nephrology, and ADA, that means endocrinology. And both societies recommend low sodium diet and target dietary protein of 0.5 gram per day. We will see why they have they recommend this kind of protein or this level of protein for patients with diabetes and CKD. And higher protein diet at early stage because not only to allow for reduction of carbohydrate, so which will contribute to help the patient to control better their diabetes. Because you know that the patient must be on low carbohydrate, we should see, and nutritional can decrease HbA1c level as similar to or better than anti-hyperglycemic medication. So with only nutritional intervention, we can reduce the number of the medication used to control their blood sugar. So nutrition is very crucial for these patients. This one is what they explain, because especially for patients with advanced CKD, they decrease they decrease naturally their oral intake because they cannot eat too much. So they decrease themselves to take protein in daily diet. So it one of the risk of malnutrition already. Especially when we limiting protein intake less than 0.5 gram per kilogram per day in patients with diabetes, and he have to reduce carbohydrate, reduce fat, reduce alcohol. That will reduce caloric content of diet of this patient and resulted in significant weight loss and decrease their quality of life. Because of that, the patient encouraged to eat enough protein to protect themselves for hypocaloric state. And protein is especially crucial to avoid. They also have to avoid the episode of hypoglycemia, because you know that protein can be synthesized to give calorie from protein. While if they take a lot of carbohydrate, it cannot provide the patient carbohydrate cannot provide protein, but protein can provide carbohydrate to this patient. So protein insufficiency is linked to impair immune system, not the patient. So it will have a negative effect on both the amount and the function of immunoglobulin of the body. And so because of that, this is they explain why we have to provide enough protein to the patient, because the deficiency in dietary protein with decreased amino acid in the plasma will impair the immune system function, will enter one of first line of defense against pathogen, and will make thinner collagen and connective tissue of the body, resulting in reduce the number of antibodies and make a favorable environment for the aggressor. That means it helps to develop to make this infection more severe, and because of that, they recommend a very high protein diet for patient with acute kidney disease injury, at least 19 to 55 grams protein per day for this patient. And why they recommended the patient should have plant-based protein, because the observational studies show that high consumption of red and processed meats is associated with increased risk of CKD progression and mortality. Why? When the patient have more plant-based protein, fruits, vegetable intake, which will associate with the decline in the progression of CKD. That means plant-based protein contribute to slow the progression of CKD. And these are the intervention we can help patients to treat their nutritional problem. And they say that nutritional intervention is very convenient and safe for this patient. And this is a study for a long time ago, when they count on total amino acid, non-essential amino acid, essential amino acid, and blend chain per amino acid. You see that compared to the control, when we supply them intradialytic nutritional, you see that there will be increase on the kind of protein or amino acid during dialysis. So it's to reduce the number of patients or reduce the severity of loss of protein after dialysis. Another study also found that intradialytic nutrition by oral or by parenteral contribute to give the patient a net balance of protein after dialysis. That means we have to intervene intradialysis for this patient, for patient with dialysis. Similarly, another study also showed that when we supply them with amino acid, we can improve prealbumin, improve albumin, improve lean body, and especially we reduce interleukin IRA, one of the cytokine or the marker of inflammation. So when we supply them with amino acid during the treatment, we can reduce inflammation of these patients. Similarly, oral protein supplementation alone, even alone, not intradialytic in the parenteral way, we can reduce the risk of the patient. And but what kind of oral we had used, or what kind of solution we should use? In principle, we have to use a renal specific oral form or oral IV solution, because there are many kinds of solution. Amino acid solution, you know, many solutions reserved for normal patient, but for patient with CKD or dialysis, it's different. So we have to choose which one is specific for renal specific for this patient. And this show that when we supply them with renal specific nutrition, we improve their serum albumin, prealbumin, and HbA score as well. And another study, when we compare between the oral supplementation and not receive over-transplantation, we see that in this study, the mortality, the probability hospitalization of patients with supplement oral amino acid reduced compared to patients without oral specific formulation nutrition supply. Another study also showed that you see that even intradialytic parenteral nutrition or oral both improve. And for oral, you know that it's very useful for patients on the day without dialysis. It's usually I don't know here where how do you do in here, but in Vietnam when we during dialysis we usually infuse the patient with solution amino acid, such as neomycin during dialysis, and before outside dialysis on the day without dialysis we provide them with oral form of amino acid. Besides the quantity, we have to pay attention to the quality of protein. What does it mean, the quality? The quality, that means the protein must be contain high biologic value. That what we will explain there, because this is an important factor. They found that there's a relationship between macronutrient with immune system. So not only the quantity, but the quality of protein provided to patient also very important. Why? Because you know there was a study in Japan. They study the relationship between essential amino acid and non-essential amino acid in patients with CKD or dialysis. You see that in not more people, the ratio between the two, half and half. That means 50% essential and 50% non-essential amino acid in our body. But for patient with CKD or for patient on HD, in this study, they found that the ratio of essential amino acid reduced compared to non-essential amino acid. So if we want to supply to this patient with any kind of protein, we have to choose any or to select any product which have a more essential amino acid than as non-essential amino acid to make again the balance between the two in the body of the patient with CKD or dialysis. And because of that, you know that the guideline from the Europe also recommend that the patient on dialysis or on PD must be provided at least 1.2 to 1.5 protein per kilogram per day, in which more than 50% must be high biologic value protein. That means what kind of protein, high biologic? The other guideline from KDIGO also recommended the solution with high biologic protein amino acid more than at least 50% higher than normal. What are the protein of high biologic value? This protein contain a lot in eggs, in lean meat, in fish, in dairy, because this food contain all the essential amino acid and which can help to increase the immunity or decrease the inflammation in the body of the patient with CKD. And some amino acids such as arginine or glutamine, they are not essential amino acid, but in some circumstances, they become essential amino acid. So we also need to add these amino acids during some stage such as sepsis, for example. And these are high value protein. That means any kind of protein which contain all 9 essential amino acids as you see on the slide. Why we call it essential amino acid? Because the essential amino acid cannot be synthesized in our body, and we have to provide them for everybody, and not only for patients. For us also, we have to provide the amino acid from outside, from the fruit or from any kind of products we will analyze. So this protein, essential amino acid, cannot be synthesized, as I said, and cannot be synthesized in our body. So we have to provide them to this patient. And increase supply, of these essential amino acid. There are 3 in red color. That means they are branched protein. We will see why they are different from other essential amino acid. And because you know that when we increase the supply of branched protein and branched amino acid up to more than 50% in polymorbid patient, we provide that because to prevent muscle loss and strength respiratory muscle. During pandemic, you know that because of malnutrition, the patient had not enough essential amino acid, especially valine, isoleucine, and leucine, so they cannot breathe. So we have to provide them a lot of this kind of amino acid to help their respiratory muscle so that the patient can breathe normally. So they are very important during infection status, especially during sepsis. And you see that leucine have to contribute to the protein synthesis, contribute to energy production, contribute isoleucine, contribute to blood sugar regulation, to muscle growth and repair, to hemoglobin formation, to energy regulation, contribute to energy metabolism, muscle mineral healing, and body nitrogen balance. So these are the role of branched amino acid in our body, which help our body to improve many disorder happening in our body during sepsis or even during malnutrition. So the abnormal plasma branched amino acid will result in discrepancy in organ amino acid change, which will result in organ dysfunction. So when we add a branched amino acid patient, we will improve plasma amino acid, improve nutritional acid, and improve the organ function in the body. So they are the most 3 important amino acid in the group of essential amino acid. So we should choose any kind of product with the composition, with the higher concentration of the concentration or level of the amino acid in the formula. If the patient eats, you see that when the patient eat enough of protein, especially protein for the originated from meat, from chicken, from fish, and from milk and dairy foods, there will be increase of phosphate in the body. And you know that in patients with CKD especially and dialysis, phosphate increase in the body. If they eat this kind of food, there will be a risk of increase more phosphate in the body with the consequence on cardiovascular system of the body. Furthermore, the patient with advanced CKD, they represent anorexia, so they cannot eat enough of protein from the food. Because of that, sometimes we have to supply them with any kind of product from pharmaceutical companies, for example. For example, here we have amino acid, a kind of amino acid under the powder. The powder is very easy for patient to intake. And you see on the composition of this kind of amino acid, it contains a lot of isoleucine, leucine, and valine. These are the 3 branched amino acid we need for our body. And so this is the slide showing that for patient with CKD, you see that the reduce in essential amino acid, increase in non-essential acid. When we add them with MU, for example, we increase what? We increase essential amino acid, which will contribute to the protein synthesis. And you know that when there is not enough essential acid in our body, the metabolism of non-essential acid will increase the BUN. So when we add amino acid for this patient, there will be protein in synthesis, and there will be less BUN formation in our body. Then you will see that the result of this kind of hemodialysis when we add to patients with malnutrition. And what they say for what did they say in guideline? They say that in patient with CKD 3 to 5 days, in 5 days that means a patient on dialysis or post-transplantation, they suggest that the patient must have a minimum of a 3-month trial of all nutritional supplements to improve nutritional status. So if the patient cannot eat enough, and if their serum phosphate level is very high, I think it's better to provide them with this kind of amniosis instead of amniosis from the fruit. So that's the guideline recommended us to treat the patient when we supply them with any kind of amino acid. And if you want to use intravenous form, we can use NeoMEU. In Vietnam, we prescribe this kind of solution a lot. As I said earlier, during dialysis, nephrologists usually prescribe this solution to infuse during dialysis for almost all patients on dialysis, because this product is reimbursed by insurance. You know, in Vietnam, dialysis in general, including medicine, are reimbursed by the insurance. So doctor have a right to prescribe these products for these patients to improve their nutritional status. And so neoanalysis is not only indicated for chronic kidney disease and acute kidney disease. Sometimes we also prescribe it for patients with hypoproteinemia malnutrition, especially before and after surgery. This kind of solution in principle preserved to patients with CKD or on dialysis, but we can prescribe it for patients before and after surgery to improve their nutritional status. As you saw earlier, branched-chain protein diet, branched-chain protein, especially valine, is very important for wound healing. So when we provide this patient with this kind of solution, we can accelerate the wound healing of patient with surgery, any kind of surgery, especially for patient with major surgery. This is the composition of concentration. When we compare with between the two kind of solution we usually use in Vietnam, including NeoMEU, Kidmin, and Nitrosteril, the ratio between essential and non-essential of NeoMEU is highest. That means they contain more essential amino acid than others two solutions. So if it's up to you, we can choose any kind of this. But for essential amino acid, NeoMEU contain more essential acid than other kind of solution. This is a clinical study of with the treatment with AMEU or NeoMEU. We show you that every parameter, serum albumin, etc., improve when we compare before and after treatment. Regarding the sign and symptom, we also see that they improve the symptom of the patients when we compare before treatment. As well, this is another slide comparing between the two. This is the post-marketing surveillance in Japan. So during the treatment and after launching the product, they continue to follow up the patient, have NeoMEU or AMEU. Then they found that they improve very good their nutritional status and as well improve their sign and symptom of the patients. The same. So that's why the data, in my opinion, is very important for this talk. You know, that's the guideline for protein in CKD go through many stages. And regarding the US, in the past, they all recommended low protein diets. There was only one from UK. You said that. Nice. They recommended the higher or the normal protein diet for patients with CKD. So what did they say in CKD KDIGO guideline in 2023? Just in July, they launched a fairly new guideline. They said, you see that, advise people with CKD to adopt healthy and diverse diets with higher consumption of plant-based protein compared to animal-based food and lower in consumption ultra-processed foods. That's the first important thing. And the third, for regarding protein intake, they suggest maintaining protein intake of 0.0 gram per day in patients with CKD from stage 3 to stage 5. No more less than 0.8, like from 0.6 to 0.8 and from 0.4 to 0.6. No, just maintaining for season 0.8, just one. And do not restrict protein. That is very important for patients with sarcopenia, cachexia, or condition that result in undernutrition. So when we prescribe any kind of protein diet for the patient, we have to evaluate the whole body of the patient before prescribing any kind of protein diet. And avoid high protein intake. More than 1 gram per day is not good for patients with CKD. And in my opinion, for Asian people, even I think here or even in Vietnam, we don't have a habit to eat too much protein. So I think that we are already on low protein diet. So do not, I think there's no necessary to recommend that, you should go low protein diet. You know, I saw many patients coming here to see me just only because of cachexia or undernutrition because of the protein restriction prescribed by other doctor. When they come to see me, I advise them, you come to now, there's no any other treatment. You should have a normal diet. Of course, they have to low salt diet, not too much sugar in diet if they are diabetic, and you eat normally, you know, just after 1, 2, or 3 months with this kind of diet, their kidney function improved very, very good without any treatment. So nutrition is very important for the patient because, you know, because they launched this guideline, KDIGO has performed a systematic review of randomized trial and found no conclusive evidence that restriction protein diet less than 8.1 improve kidney or other health outcome among patients with diabetes. So that's the reason why now they recommend 0.8, only one number we should know. And this the level of protein the patient, the normal people all over the world could eat. Because neither lower nor higher protein intake appear beneficial and each is associated with potential harms. That's my last message for this conclusion. Thank you for your attention.
Thank you, Professor Pham Van Bu, for the remarkable presentation. Now it's time for questions and answer session, and I would kindly like to invite the Honorable Chairperson, Professor Tu Zathe, and the Honorable Speakers, Dr. Thiha Su and Professor Pham Van Bu, up on the stage for the question and answer session. We would be pleased if the audience does not hesitate to participate in this session.
Yes, you are in the middle.
Thank you everyone for the for an interesting topic. So for the first speaker, Dr. Jyotia, so I would just like to give two comments, not questions. The first one is regarding your point about the proteinuria and the need for CKD progression, because you know, whenever we advise the other doctors and specialists for nephrologist referral, one of the indications, of course, is gross proteinuria. But I think the more important issue is the persistent proteinuria, which is more dangerous. Because you see, some of the patients, they have proteinuria which is not in the nephrotic range, but the persistent proteinuria, in spite of giving adequate treatment, and this patient has more likely chance to go into ESRD or later stages of CKD. So this is one point that I would like to emphasize. And the other point is regarding the onset of AKI and the relationship to CKD or ESRD. Previously, we all understand that AKI, if it is resolved completely and the biochemical levels return to normal, we presume that this patient has no more renal problem. But nowadays, they have several papers that show that even if the biochemical levels return to the pre-treatment levels or the pre-AKI levels, these patients tend to have a higher chance of developing chronic kidney disease in the later years. So this is one concept also that needs emphasis. So once you have got a definitive episode of AKI, especially some AKI that needs real hospitalization or treatment, there is always a chance of developing this CKD. And you need to educate the patient for them to consult with a nephrologist for reassessment in the later years, even though the patient may seem normal at the present stage. That's also one point. Regarding Professor Pham, he's a very good colleague of mine. We've been together in many meetings. You're talking about the intradialytic nutrition as well as the interdialytic nutrition. Now, there's some people who think that, giving very high nutritional supplements during the dialysis or the end-stage patients is beneficial for them. For example, just using the total parenteral nutrition. I don't agree with that, but there's still some physicians, they like to give TPN in ESRD patients. So what is your opinion regarding the benefits or the usage of TPN in these kind of patients?
Benefit and
Total parenteral nutrition.
of the
TPN bags,
yeah.
What do you think? What is the role of TPN in ESRD patients? TPN, total parenteral nutrition,
Yeah. You know that for patient on dialysis, we usually use AVF to make dialysis more effective. We have to protect them, permeability of protect them. If we infuse them with solution content, including glucose, lipid, and protein, the presence of glucose and lipid will increase the risk of thrombosis of these patients. And the other thing we should know that For example, I don't know here, in Vietnam, we have to reduce in many centers. In our center, a little bit different. But in other center, we have to reduce the dialyzer up to 6 times. Because the insurance only reimburse with a fixed price for every session of the dialysis. So they have to reduce dialyzer to reduce the cost of treatment. So for reducing the dialyzer, if we infuse them with this solution, there will be coagulation in the dialyzer. So because of that, we almost never, of course, in some special cases, when the patient presented with not only lack of protein, but also carbohydrate inertia, for example, in that, especially for patients in sepsis or after surgery, sometimes we have to prescribe total solution for them. But the indication is very limited, and we usually prescribe renal specific solution for these patients.
Yes, thank you. That's just the point that I want to.
Yeah.
I totally agree with you, because unless there is a specific indication for the TPN, we shouldn't give it to our patients. One of the wrong concept is that by giving TPN, they think that it is much better nutritionally, but in fact, this is the counterproductive effect of the TPN in such patients. And the other point, of course, also is that we should never give it in the peripheral line unless you have a central line for the TPN. This is one point that I would also like to emphasize. Thank you.
Yeah.
First of all, I want to thank all the participants, and then I want to congratulate both of the speakers. As it is already known that diabetes mellitus is the most common cause of chronic kidney disease. In the management of diabetes mellitus, where oral hypoglycemic agents are used, as far as I know, metformin, DPP-4 inhibitors, GLP-1 receptor agonist, and SGLT2 inhibitors. These 4 groups of oral hypoglycemic agent possess renoprotective effect. Apart from metformin, it also has renoprotective effect, but it is only the one kind in its group, biguanides. And other 3 groups, up till now, there have been 4 or 5 drugs that US FDA has already approved. Now my query is, are sulfonylureas also, do sulfonylureas possess renoprotective action? If you can answer me, I will be very grateful. Thank you very much.
Yeah. Okay.
Thank you for questions. Yeah. So as you know, the our hypoglycemic agent and the diabetes agent, they all reduce A1C level, and if we can get the target A1C level, we can prevent the macrovascular complication, including the renoprotective action. So in advanced trial, they have been using the gliclazide MR for reducing their A1C level. But for cardioprotective effect, now they more favor the SGLT2 inhibitor and GLP-1 analog than the other agent because of their cardioprotective action. So they are now using in first line together with the metformin, and the diamoclone, like the glycoside MR can be also be used if the glycemic control is not satisfactory.
I just to know that does glycoside possess renoprotective action?
Regarding these drugs, my opinion first about regarding sulfonylurea, because it's as used. You know that in general, the hypoglycemic effect of SO is the most potent when we compare with other anti-hyperglycemic drugs. Because of that, there's a risk of hypoglycemia. But there are contraindications for advanced chronic kidney disease, except two kind of sulfonylurea. The first one is glipizide. I didn't know whether it's available here or not. It's not available in Vietnam, only in the US. The second one, one is glipizide. It's available in Vietnam under the name Diamicron from the Servier company. So we can prescribe this medicine for patients on dialysis or in advanced CKD. But the risk of hypoglycemia compared to other sulfonylurea, these two drugs have less hypoglycemic effect than other sulfonylurea, but still have. So when you prescribe this kind of medicine for the patient, we must pay attention to this effect. Another one is that now the role of the treatment for patient with diabetes is the level of H1C is not very important. That's more important than that. With the effect of the treatment of diabetes, any kind of drug must have cardioprotective effect. Because of that, they did a lot of clinical trial in which I participated as a nationalist investigator for DAPA CKD, you know. In this trial, they proved the efficacy of dapagliflozin in patients with chronic kidney disease with or without diabetes. And now in the new guideline, this kind of drug also have also be indicated to treat the patient with CKD without diabetes if their GFR from more than 20 milliliters per liter. You know, the new guideline, we can prescribe this kind of medicine for patients with CKD. Yeah? You don't care about what the cause of CKD. Is it due to diabetes or not? Due to diabetes, not a problem. The patient with CKD, we can prescribe SGLT2 inhibitor. For patient with GFR, is still more than 20 milliliters per liter. And with the patient with associated with albuminuria more than 200 milligram, the evidence of the degree of evidence is 1A, very strong. And if the albumin level in the urine less than 20 milligram, the level is of 2B, less strong, but still have a indication, especially with the CKD presented with heart failure. You know, because this kind of drug, SGLT2 inhibitor, when it was born, just only for patients with diabetes, but now it can be indicated or prescribed by 3 specialties: cardiology in patients with heart failure, nephrology in patients with chronic kidney disease, and in diabetes for patients with diabetes. And metformin is not indicated anymore for patients with GFR less than 30. Because of that, in the new guideline, when they recommend that we should use SGLT2 inhibitor for patients with eGFR more than 20, there's no role of metformin anymore with the patient, in patient with GFR less than 30. And GLP-1 is still very new. And in the near future, MRA will be indicated. Now, for patients with CKD, we have 3 pillars of treatment. The first one is RAS inhibitor. The second one, SGLT2 inhibitor. And the third one, MRA. But the base must be stop smoking and lifestyle modification. On the base of lifestyle modification and smoking, there are three main pillars up to date: SGLT2 inhibitor, MRA, and RAS inhibitor.
Okay, thank you very much, Professor, and thank you very much, Dr. Thiha, for your answers. I'm really grateful to both of you. Thank you.
Good evening, and congratulations to all the speakers. They have delivered very excellent talk, especially about the new things, new advances. Okay, I have the few things to raise to ask Professor Pham Van Bui regarding just now you had mentioned, earlier you mentioned about the albumin. The higher the serum albumin, the better the prognosis of the patient, right? Okay. In that case, is there any cutoff point?
Yeah.
In that cutoff point, we had to maintain, well, we had to achieve to improve the patient the outcome.
Yeah.
Number one. Number two, in our old school of thought, because in chronic kidney disease, there's a huge loss of protein through the urine, huge loss of protein. And then, on the other hand, the therapeutics, they recommend to give the low protein diet. And then a supplement also must be low in protein. Like we give the oral enteral feeding and also the partial or total parenteral nutrition. So sometimes I was in dilemma what to do. On one hand, we need the protein. Patient albumin level is very low. We need it to the optimal level. And on the other hand, we are restricted to give the protein. So how to manage this? But just now, Professor, you had mentioned that nowadays they recommend to give the high protein, no more the low protein, right?
Now for protein.
Yes.
Protein.
Okay. Can you please explain about all these things? One is albumin.
Yeah.
Okay, cutoff point, and another one is regarding the low protein and the CKD. Thank you very much.
For the first question, you know that the patient with CKD is very hard to increase their serum albumin. So they don't mention about the cutoff level albumin, serum albumin, you should stop to increase. But the author only tell about the protein intake must not be higher than 1.3 gram protein per day for this patient. For a patient with CKD, not for normal patient. But even for normal patient now, they recommend that we should not take more than 1.5 gram protein per kilogram per day. In Asian country like Myanmar, Vietnam, we have no habit to eat too much. But in Western country, they eat a lot. Usually they eat more than 1.6 gram protein per kilogram per day. Maybe this is one of the factors contributing to the prevalence of CKD now. Of course, we have many other factors as well, but high protein in diets contribute very high protein diet contribute to the prevalence of CKD now. For patients who present massive or severe proteinuria, of course, in that case, we have to control. The most important step, we have to control protein in the urine. And we have many means to control them. The first one, when we prescribe RAS inhibitor, we should insist the patient on low salt diet, because the effects of RAS inhibitor will be lessened if they continue to take normal salt diet. They have to reduce normal salt diet. So some doctor, authors said that in spite of any kind of treatment, I don't want to know. The problem is that when you exercise any medicine, any kind of therapies, that must reduce albumin in the urine. If they cannot reduce in the urine, that means this therapy is not effective. So the first one is the patient must be on low or no salt diet. The second one is that they increase the fact that we have to increase the dose of RAS inhibitor up to the dose tolerated by the patients. You know, first, when I met these specialists, I discussed a lot with them. And I asked them that even in the case that with, for example, lisinopril, 5 milligram, you control proteinuria of this patient already, but they still recommend to continue to increase the lisinopril up to the higher dose if the patient tolerated to the maximum dose. Why? Because then that when we increase the dose of medicine, the protection, cardio and kidney protective role of this drug will increase. So they recommend us now to prescribe this medicine and to titrate up to the tolerated dose of these patients. And if with one medicine you cannot control the proteinuria, you have to associate it with another. Of course, we cannot recommend, they don't recommend the association between ACE inhibitor and ARB. No, there's contraindication. But we can associate the ACE inhibitor or ARB with MRA, for example. Why we don't have a phenylalanine, we can prescribe spironolactone, for example. And even NK kind of Thiha-like diuretic, it contributes to reduce protein in the urine. And the third one is the beta blocker, also have to reduce protein in the urine. And the fourth, plant-based or vegetarian diet contribute to reduce the protein in the urine. And if the patient have a contraindication of RAS inhibitor, or if RAS inhibitor associated with low salt diet, associated with beta blocker, associated with beta blocker, associated with the MRI, for example, but we still cannot control proteinuria. How can we do? In that case, we can add one more CCB, cancer blocker. But, you know, in principle, cancer blocker will increase protein in the urine. But there's a difference among cancer blockers. The first to the third generation will increase protein in the urine, but the fourth generation, like I know that you prescribe a lot here, is very good. Atilac contribute to reduce the protein in the urine. So there is study in the Japan when they compare between Atilac and losartan regarding hyperkalemia risk and proteinuria. Atilac, that means sinidipine, is more effective in controlling proteinuria than losartan. It's very surprising, this kind of study. So, and with when you combine all the drugs, you cannot reduce the protein in the urine. That means the injury of the kidney already becoming organic. That means there is a fibrosis, glomerulosclerosis or fibrosis. In that case, the progression of the kidney disease will very fast, very fast, and we cannot control that.
Thank you very much, Professor.
I just want to give a comment on the previous gentleman who asked whether, you know, in diabetic kidney disease, the role of sulfonylurea in the, is there any renal protective effect? Actually, you see, there are 2 points. First point is that any oral hypoglycemic agent or even insulin that can lower the blood sugar levels, the glycemic control, this in itself has some sort of an effect on the renal protection. So by that means, because you are lowering the blood sugar levels, you have a sort of renal protection. But the SGLT2 inhibitors and now they are talking about this GLP-1 inhibitors as well, agonists as well. They have an additional renal protection effect due to their direct actions or mechanism of action. So this is somewhat similar to the role of RAS inhibitors in control of hypertension, because we always ask what is the best drug to control hypertension and CKD. And actually, any antihypertensive agent that can control or lower the blood pressure will have a similar protection for the renal. But the RAS inhibitors have a direct effect on the glomerular vessels. And by this, they can reduce the progression of the CKD and the fibrosis, glomerular sclerosis, things like that. So that is the point, I think, that will answer your question. Thank you.
One more thing I would like to add, in controlling the proteinuria, metabolic acidosis is also play a role. We usually forget this role of metabolic acidosis, but it's very important. So now it's recommended and insist on recommendation, the role of metabolic acidosis in the progression of proteinuria, progression of CKD, and the risk of cardiovascular. So according to our colleague, he just presented the role of metabolic acid, but indication for supplement only when metabolic acid is less than bicarbonate, serum bicarbonate less than 16. Now, no, less than 20, higher. And we have to keep to maintain serum bicarbonate near normal value. Not higher than normal value, but near normal value. But in the past, from 20 to 28, now, no, near normal value. So metabolic acid is also a very important factor we have to pay attention to when you want to control the progression of CKD, the risk of cardiovascular, as well as the presence of proteinuria.
So regarding with the serum albumin levels, I want to add one thing. So in patient with the CKD on hemodialysis, if the serum albumin level is less than 3.5, which is a lower limit of the normal, there's an increase in mortality. So we should keep the patient above the more than 3.5 or normal albumin level in CKD dialysis patient. If the serum albumin level is less than 3.5, there's an increase in mortality risk.
Suppose if the patient is CKD and had a protein losing nephropathies, and then albumin is low, so can we give the albumin supplement like human albumin? But in our setting, it's not possible because very, very expensive. Now we can usually we just get for the 5 days only, 5 days regime only. We give this human albumin on long term if the patient can afford? And another thing is, instead of giving human albumin, can we give the parenteral amino acid, provided the liver is okay? Is it? To get the just now what Doctor you mentioned about to maintain the albumin level, that level.
In dialysis patient, more than 3.5.
More than 3.5. Yes. Yeah. Is it okay or not?
So you mean the proteinuria is in CKD or in nephrotic syndrome patient?
Or in the something like the protein losing.
Protein losing, yeah. So in some nephrotic syndrome patient, we are given the concentrated albumin, it's a 20% human albumin.
Yes, correct.
Because But the only thing that the main thing is we need to find out the cause, and we need to treat the patient, treat the cause.
Yes, yes.
So we need to treat the GN or nephrotic syndrome. So
Yes,
that's the
yes.
main thing. But before we can reduce proteinuria. So at the time there's a risk of the thrombosis because the patient is a very edematous and there's a
correct.
hemoconcentration it can lead to, and also there's a loss of the antiplasmin or something like that.
Correct,
So
yes,
there's an increased risk of the thrombosis. And so at the time we need to give if the patient is not in failure, we can give the albumin so for the risk of the prevention of the thrombosis, and also the RA resistant elevation can also be reduced because of there may be the same RA resistant elevation with the hemoconcentration edema. So that's at the time it will be relieved. So and also addition to that, the albumin is the carrier protein for diuretic. So if we give the protein together with the diuretic, the diuretic action may be good. So that's why at the time we are given. But for the CKD with the proteinuria, we usually don't give to correct the albumin.
Yeah. Okay.
I have, excuse me, I have a quite different opinion regarding serum albumin for patients with protein-losing nephropathy. We can. Because you know, when the patient protein-losing nephropathy is very difficult, there is inflammation in the body. This inflammation explains why the patient has hypoalbuminemia. Thus, even they count that, even the protein lost in the urine more than 20 grams per day, the liver can synthesize this kind of protein up 20, 30, even 100% to compensate the protein loss in the urine. So, if we use them with albumin solution to cause inflammation. We increase inflammation in the body of the patient. So we never improve the albumin status of this patient. Instead, we have to provide them with amino acid for the liver synthesize them into albumin is better. And in another way, we only indication albumin infusion just in one case. If the patient needs dialysis because of hypervolemia, very, very severe edema. So in that case, there is an intravascular volume depletion due to low albumin in the serum. So in that case, with the serum present very excessive water volume expansion. So to withdraw this volume, we have to infuse albumin in the vascular compartment to withdraw more water from extravascular into intravascular to be withdrawn by dialysis. That's the only indication for patient with and even in losing protein, there is no role of albumin because it's no effect and it's increased inflammation. Because of that, you see, you can read any kind of recommendation on nutrition. There's no any work about serum albumin infusion for this patient. No. So no indication for nutrition.
I want to add the one thing. If you have a proteinuria, hypoalbuminemia, need to check the liver function. If there's a proteinuria, liver can synthesize and replenish up to the 6th time. If there's a hypoalbuminemia established, liver compensation failed that indicate the excessive loss of the protein from the kidney. Yeah.
And in some cases of proteinuria we cannot control by medical treatment. And if the kidney function is still very good, In that case, we have to do kidney biopsy to see whether we have to apply any kind of other treatment, including immunosuppressive treatment, for example. And we did a study. We studied about the non-diabetic glomerulopathy in patients with diabetes. And we found that 20% patients with diabetes presented non-diabetic glomerulonephritis, especially in patients with we cannot control their proteinuria.
Okay, thank you very much, sir.
So the question is, how can we advise a patient with a CKD to restore the salt intake to the recommended level in the user-friendly way? Thank you for question. So actually, so we need to advise a high salty diet. We need to advise a patient to avoid the high salt diet, like the being a chop, according to their recommendation, the 90 millimole per day is maybe the patient may don't know easily, so it may be confusing, and so we can give in a straight way like the salty diet to avoid the salty diet.
Second question.
Another question, do we need to treat biochemical hyperuricemia in CKD patients? If so, what will be the rational choice and how long should it be taken? According to the new guideline, they don't recommend us to treat asymptomatic hyperuricemia for patients with CKD. But in my experience, this I don't agree with the author about this case. Of course, we usually, for example, we rely on the level of uric acid to be treated. If the uric acid just higher a little bit than normal value, we ask the patient to change, to modify their diet first. And after 3 months, I control. We check again their blood, the uric acid. If it continue to increase, we have to treat them. Without, and thus the patient still have no any sign or symptom due to hyperuricemia. And I found that when I've monitored the patient with CKD who present hyperuricemia, whenever I can control their uric acid, uric acid in blood, the progression of the CKD is low. When I cannot control, it continues to progress. And when we add again, enter uric acid to this patient, continues to slow. Now we have in the treatment of hyperuric acid, we have 2 kinds of medicine. One, it's increase the elimination of uric into the urine. This kind of medicine is not available in Vietnam. In the past we have, but now they don't produce anymore. And so we have to rely on the second one. That means that helps to reduce the production of uric acid in the body. And for this kind of drug, we have 2 in Vietnam. The old one, the allopurinol, everybody know, is very cheap, but the side effect is quite common, especially for patients with HLA-B21. The reaction very, very severe. We met some cases with the Steven Johnson, even Liege syndrome, very severe. And now in Vietnam, we have a new one, but much expensive. That's a Feburosta. It's very effective. And usually we prescribe 40 milligram per day only. A tablet 80 milligram, but I always prescribe only a half, 40 milligram, even for patient without CKD. And it controlled very good. Once we control the uric acid under the normal range, and we continue to how to say, to from every day to alternate day. And if continue to control, we shift to 2 days per week. After 3 months more, if they continue to go down or stable, I stop and continue to monitor the level of uric acid of these patients. And according to the guideline of rheumatologists, as a rheumatology society, for these patients, usually they recommend to take this medicine forever. But in my experience, we can change the dose, modify the pill, we rely on the response of the patients. And in that case, we reduce the dose, and we reduce the risk of the effect of the allopurinol, even febuxostat on the kidney. You know, both can cause an interstitial nephritis. So I don't like continue forever. Just we can prescribe it for patient with gout, but it's very effective, you know, because it will help to shrink the trophy. I remember that I treat a Malaysian patients when he came to see me in FV Hospital. FV Hospital is the French hospital, invested 100% by French doctor, and I worked over there as a consultant and advisor for director board. And when he came to see me, he presented a lot of trophy along the choice. And after 3 months, all trophy become softened and then shrink. And he was surprised, and he asked, why Malaysian doctor don't know this medicine? I answer, I don't know, but this medicine is now available in Vietnam, so I prescribe to you. So it's very effective, but it's very expensive, about $1 per tablet. So sometimes we have to think much about before prescribing this kind of medicine to poor patient. Instead, we can prescribe allopurinol, but you know, allopurinol is contraindication for patient with advanced CKD. While for febuxostat, we can prescribe a half dose for patient, even for patient on dialysis. So it's very easy to prescribe them. The problem is that the price in Vietnam, and we have also generic from India, but compared to the brand name, not very cheap. For example, Vietnam for one tablet of brand name about $1. One tablet from India, $0.9 less. So I never prescribe generic for this patient. Not very cheap. Is there any noticeable difference between erythropoietin alpha and beta? No. Almost we can. There is no any head-to-head study between the two. So we can say that you can prescribe either alpha or beta. Maybe there's, or not maybe, I'm sure that there's a difference between the biosimilar and the brand name. Because I did many studies comparing between the brand name and biosimilar. In erythropoietin, because for protein, biosimilar, for protein product, we call them biosimilar. We not call them generic. Generic only for chemical tablets. For protein tablet, we call them biosimilar. And I did international study comparing between the brand and the biosimilar. There are many differences between the two. The first one is the impurity of the biosimilar. They contain a lot of strain protein in the solution. That may be one of the cause of allergy or any kind of resistance. The second one is that the packaging is different. You know, for product made with protein, the packaging and the transportation is very, very delicate. Just a little changing that can destroy the composition or the structure of the protein. And the third one is the dose in biosimilar is not stable. Sometimes on the label, you see 2,000, but in fact, it maybe 2,500 or maybe 1,800. So the dose is not fixed. So for us, sometimes it's very hard for us to adjust the dose based on the resident of patients. So for this kind of medicine, we have a lot of biosimilar in Vietnam. Now we have also a product. I heard that it's also very successful here. Product from Nanogen. I did a study comparing a product from Nanogen compared to a brand product from the US, dark apoetin alpha, long-acting erythropoietin. For the first result, are both are the same effect. Now we are go in detail about side effects, etc. And maybe in the future we have a conclusion about the similarity between the two products or not. May I know about total nephron block approach in pre-existing prescribing diuretic? I don't know total nephron block. I know that. I don't know if it's the question of our colleague. Right now we can say that it's we eliminate osmosis diuretic for sodium blocking in the tubular nephron. We have three. One, thiazide or thiazide-like. The second one, loop diuretic. And the third one, aldosterone antagonist. And the strongest is furosemide is loop diuretic because it inhibits absorption of sodium in the loop of Henle. You know, in this side, it inhibits the absorption up to 30 to 40% of sodium from the urine. And in the distal tubule, thiazide or thiazide-like inhibit about 10 to 20% of sodium absorption. And in the collector tubule, it inhibits about less than 10%. So the stronger diuretic is loop diuretic, then thiazide or thiazide-like in the distal tubule. And the third one is the aldosterone antagonist in the collecting tubule. So in principle, we can combine three: furosemide, dialysate, furosemide, thiazide or thiazide-like, and anti-aldosterone at the same treatment because each effect on different part of the nephron. But we cannot associate two medicine in the same group. For example, we cannot associate furosemide with bucetomide, a kind of loop diuretic, stronger than furosemide and longer action than furosemide, but it's not available in Vietnam. But we can combine between furosemide, thiazide or thiazide-like, and anti-aldosterone diuretic. We can combine depending on the regimen of the patients. Role of parathyroidectomy in renal bone disease. You know, it's very important. So we have to follow the PGS in patients with CKD and or dialysis. You know that dialysis eliminates poorly phosphate from the blood. So in the long run, the higher phosphate in the serum of the patient will increase the PTH from the parathyroid. And when PTH increase more than 800 micromole, we have to detect whether the patient have a hyperparathyroid. If patient is due to adenoma of parathyroid. And I don't know whether you have this kind of ultrasound in Myanmar or not, but we have in Vietnam. Since then, we discover a lot of hyperparathyroidism due to adenoma of parathyroid. And for the patient, when we intervene by surgical to remove adenoma, the PTH and phosphate in the serum of this patient drop strikingly. And after some time, when we check bone mineral, bone density, for example, is improved. So in the case of hyperparathyroidism due to adenoma of PTH, we can do surgery. It's very easy to do. It takes about 30 minutes to remove the gland. And I operate many cases in Vietnam because I'm the only one in Vietnam who can do, who can get at the same time in both surgery and internal medicine. So I do surgery myself for this patient, so I know the result. And for patient with PTH without adenoma, the guideline recommended, and we have to prescribe them vitamin D3 to increase Thiha first, and then if phosphate in the serum is still very high, in that case we add phosphate binder. And in the future, we have now Sivalame in Vietnam, not brand name, but generic name from India. But unfortunately, they are still very expensive. So only patients who have money to buy them to control PTH. You have all the...
So one question, Professor. So regarding the Medicare parathyroidectomy, Senaselect, so how you prescribe for that? Because we not available here yet. So when do you start using the Medicare parathyroidectomy Senaselect in hyperparathyroid patient? For hyperparathyroid patient?
It's improved. They improve immediately after surgery, especially if the patient presents adenoma. And for patient with adenoma, it's quite hard to control. But we have to improve the dose of vitamin D and then the dose of Sivalame to reduce the phosphate in the serum and to counter the effect of PTH on the body. So it's effective. But even vitamin D3 is also expensive. So our prescription is still very limited to patients who can pay for the treatment because they are not reimbursed by the insurance. Almost more than 90% of medicine for CKD in Vietnam reimbursed by insurance except Sivalame. Maybe in the near future, with our suggestion or our proposal from our society, the Minister of Health will approve for this medicine. So in that case, we can prescribe easily for this patient. Vitamin D3 is not very expensive, but Sivalame is very expensive. And we have the last question. Which target level of LDL should be maintained in CKD? Like in cardiovascular disease, we have to maintain LDL less than 60. That's the ideal level for this patient. And maybe, and in my But for patient with CKD, especially patient on dialysis, very low cholesterol maybe means malnutrition or undernutrition. So in that case, we have to check all the parameters to see whether patient have malnutrition or not before prescribing any drug to control their LDL cholesterol.
Any question? It's time to wind up the today symposium. Sorry. Two speakers comprehensively talk about the progression of the CKD and update the management of the CKD. Either treatment of the albumin during albumin, hypertension, glycemic control, and then the anemia. And second speaker deliver about the importance of the healthy dietary pattern to the slow down the GFR reduction and keep the adequate protein to reduce the serum creatinine and prevent the development of the malnutrition. And the importance of the Phuong syndrome in the CKD, and it can lead to the cardiovascular complication, infection, prone to get the infection, and the impair the quality of the life. So need to prevent and treat the Phuong syndrome in the CKD. And treatment of the protein treatment in the dialysis patient to maintain the adequate albumin level to survival of the CKD patient by giving the oral nutritional supplement and the branching amino acid supplement. And another thing is important, very important, is a nutritional management that indicate the nutritional management to get the to improve the immune status of the patient that can prevent the infection and then the cardiovascular risk and the prevent the GFR reduction and prolong the survival. Thank you very much for the all attending audience from in person or online. Thank you.
Thank you, our Honorable Chairperson, Professor Tu Gia Tinh, and Honorable Speakers, Professor Pham and Dr. Thiha for the expert opinions. According to the agenda, it's time for the closing session. Ladies and gentlemen, I hope you have found today's presentation informative and engaging. Thank you, professors, associate professors, consultants, and all the doctors who are joining the symposium in person and also through the webinar for your time, presentations, and expert opinions. Now, it's time to announce that today's ceremony of updates on management of chronic kidney disease is successfully accomplished.